Well, you have about, with all your clicks, you have about a half an hour. No, seven's perfect. Okay. Only because I'm trying. What I'm trying to.
It works.
Okay, so
I just switched. I'll switch it back for you.
she's cute, isn't she?
She's adorable.
She's running the whole damn show, man.
I'm quite sure.
I'm the personal assistant. I told her that.
Yeah.
All the women in the family. When she was 2.
Oh no.
He said, "You can't talk to her. You're giving her bad blah blah blah."
It's totally true.
And I said, "Here's the deal. When she's a teenager, she's going to rip your eyes out.
Right.
I'll still be a person."
right. Yeah.
No stress.
Set yourself up well.
I'm thinking it. I'm planning. Yeah. Oh, yeah. No. But it was funny, Nick. I got a lot. Okay. Ooh, not on. That's not okay. Maybe it is on. Great. There it goes. Okay. Welcome to the 23rd lecture. 2 to go. Little housekeeping. I will have office hours tomorrow. Should I have office hours next week? I don't know. It's up to you guys. Yes? No? No one cares. All right. I'll send out an email. I'll send out a notification. Let's see. The exam is May 8th. From 3 to 6. The actual exam for most of the brunt of the people in the class will be 2 hours. It's 100 questions. So that'll go from 3 to 5 right here. And then other people in the class will be notified where they want to go, where they need to go for the final. So one other thing, Zoe, are you here? Where's Zoe? Zoe? I don't know. Zoe's not here. She said she was in the class, and she asked me I sent you an announcement about the Cognitive Science Conference, and I've been to it before. I've actually presented at it. It's really good. There's usually a couple, 300 people. They have a very nice speaker group this year. So it's something to think about, and the people who've done various projects present their work. So if you have time, think about going. And the information is here, the website, and also in the email I sent to class. All right, so today we're going to talk about a really interesting topic, which is what happens if you get damage to your corpus callosum, this massive fiber bundle, tens of millions of fibers connecting the right and the left hemisphere. What kind of insights does it give us into how we're organized for everyday behavior, for lateralities, for implicit processing, etc.? And it provides insights into all of those things. We already know from the class we got language predominantly in the left. We have attention slightly to the right. We have apraxia in the left. We have basically differential attention manipulation and global-local, detail on the left, global on the right. Memory, if you remember, a left hippocampal lesion produces verbal memory loss, but a right hippocampus doesn't, so even your hippocampus is lateralized. And there's a slight tendency for more deficits with right hemisphere damage in the social-emotional sphere. But in general, really the main thing is the orbital frontal amygdala pathway, and now we're going to add the insula to that. So there's lots of asymmetries, and what does the split brain literature tell us about these asymmetries? So it was done initially for medically refractory epilepsy. These are people who were starting with a seizure focus on one side typically, where they'd start jerking on one side, get a focal motor seizure, maybe it would spread, and then it would spread across the corpus callosum, and they'd have a generalized seizure, and they couldn't be controlled. So one idea was to cut the corpus callosum and try to keep the seizure activity in one hemisphere, where you're awake and your arm's jerking, but you don't have a generalized tonic-clonic seizure. And that's what it was developed for. We don't do it very often now. I think in the last, I'm going to guess 5 years, we've done one case in the various hospitals that we work with. It's still done, but relatively infrequently. So a little bit about the anatomy from early on in the course. The corpus callosum, this huge, big white matter bundle. The splenium connecting visual areas. The mid-body connecting tactile and motor connectivity. And the anterior part connecting frontal cortex and both lateral and orbital frontal cortex. And this little guy here connecting the temporal lobes. So the surgery is quite elegant. Here's someone who's had a corpus callosotomy. That's it. You see the cut there? That's it. And you've now disconnected the two hemispheres. Now, the problem is when you cut the whole corpus callosum at the same time, the patient really does not look good postoperatively. So when it is done, it's usually done in a couple procedures. The first one cuts the anterior part, and the second procedure cuts the posterior part. So what do we know about it? I think the really seminal observations were done by Michael Gazzaniga, who actually founded the Cognitive Neuroscience Society, and Roger Sperry, who subsequently got a Nobel Prize in medicine. And they did what are called tachistoscopic presentations. What does that mean? It means the patient, and you're going to see patients with their corpus callosum cut. When they look at this dot, they have to fixate on a dot, and stimuli are either presented to their right or their left field rapidly. I shouldn't say rapidly, for a short duration. And the duration you want to keep the stimulus under is about 180 to 200 milliseconds. Because if someone's fixating here and the stimulus comes on, it takes that, even if they break fixation, it takes 200 milliseconds to get there. So by keeping it short, they can't really get fixated on the stimulus. You force it to go to the left or to the right hemisphere. And it was done initially, of course, with slide projectors because we didn't have really computers to do it. So, for instance, the classic finding, this is a patient, a cartoon of a patient with a split corpus callosum. So the left hemisphere is disconnected from the right hemisphere. And basically, you present, the patient looks here and you present this key ring to them. And you ask the patient, what do you see? The patient only says they see ring, because ring has gotten to your language hemisphere. Key went to your non-dominant, non-language hemisphere. Normally, you just transfer that right over, zip in 10 milliseconds, 15, 20 milliseconds, and you'd fuse it as into key ring. But since the corpus callosum is cut, key is trapped in the right hemisphere. It's really as simple as that. Okay? Now, if you now ask the person to basically feel all the things on the table and just say, does anything seem familiar? Actually, they'll grab the key, even though they couldn't say that they saw the word key. So this means there's something in there, something's influencing their behavior, but they can't consciously access it and say to you, key. We'll talk about that in a little bit more detail. So, this is the key thing. and I didn't make these slides up. These are from Gazzaniga, so I'm not trying to get PR here. This is actually from Michael, and you'll see why he's using these stimuli later. Basically, here's the split brain from a complete split to a normal brain. So if I present night to the left field, it goes over to the right hemisphere. You don't even know it, but it's rapidly transferred to your left hemisphere language cortices, and you say, I saw night. The partial split, you're getting incomplete transfer of information. This is still going to your right hemisphere, but there's some partial cut in your corpus callosum. I have a picture in my mind, but I can't say it. 2 fighters in a ring, ancient, wearing uniforms and helmets, on horses, trying to knock each other off, knights. And he gets to it with partial information. If you have a complete split and you present night to that hemisphere, the patient says, I didn't see anything. Okay? They're not able to consciously access it. So normal, partial, complete. Now here's the actual initial patients where you're basically asking them to do things with their left hand or their right hand. This is one of Gazzaniga's 2 seminal first patients with a complete split of the corpus callosum. And let's just watch how this patient performs.
With your left hand, make a fist. With your right hand, make a hitchhiker's gesture. Good.
Eyes open.
With your left hand, make a hitchhiking gesture. Good.
Her
with your
eyes
right
are open.
hand, make with your left hand, make the motion of like using a screwdriver.
With
No clue.
which hand?
A screwdriver with the left hand.
Oh, with the left hand.
The right hand's not showing her how to do it. She has no clue. She's severely apraxic. She's heard it. She can't transfer it to the left hand.
All right, try it with your right hand.
Perfect.
Okay, now with your left hand. Okay.
Sort
Now,
of like that.
okay, with your right hand, make the A-OK sign. How about with your left hand?
She's going to mimic it because she sees
Okay.
it.
Now let's close your eyes.
Close your eyes.
Your eyes closed?
Mm-hmm.
Now with your right hand, make me a hitchhiker's sign. With your left hand, make me the A-OK sign. Eyes closed.
Eyes
No
are
clue.
closed.
She can mimic it when she sees it, but she can't verbally decode
Okay,
it.
now with your right hand, make a screwdriver. With your left hand, make a screwdriver motion.
Severely apraxic.
And move the
She
screwdriver.
threw out an old motor program,
Um,
completely irrelevant to the task.
it's sort of like
Okay, that's very good.
Okay, so you just saw the classic example. The patient, they can do things in natural life with their hands. They can pick up things. They could probably give the hitchhiker. They could do all these things automatically. And she can even mimic, if she sees the patient with her right hand do something, she can mimic it with her left hand. But as soon as she doesn't have a visual guide and she has to decode the verbal information, make an A-OK sign, do this, do that with the left hand, she can't do it because the verbal information is locked in her right hemisphere. That's the classic finding. Now, the flip is spatial ability in these patients. This is another gentleman with a complete split. And what you know, this is the patient drawing preoperatively, before their callosum was cut. With their right hand, they draw a nice cube. With their left hand, a pretty nice cube. They're a right-handed person. They're a little better, but they certainly can do the cube. They see a cube, and they have to draw it. They can do it. Postoperatively, what you find is that the person with the left hand, the nonverbal left-right hemisphere, can actually still draw the cube. They still have intact 3D perception, but now the right hand, looking at the same cube, can no longer draw it in 3D. Again, telling you that the ability to do a lot of these three-dimensional spatial operations is largely dependent on the right hand, on the right hemisphere. So here's a patient. He's being asked to duplicate this pattern with blocks. You're going to see these blocks, these cubes, put on the table. It's a pretty old and pretty grainy picture, but such is life. left hand. Bingo, right? He's adjusting. He's got the configuration, okay? So he could look at that shape and with his left hand do it. Now he's being asked to do it with his right hand. Same shape, same blocks. As you can see, he just can't do it, right? So he's lost his left hemisphere is not able to do the very important 3D dimensional analysis and control that the right hemisphere can do. This is the classic split finding. Language, left, spatial, right. Now, what about preconscious semantic integration? That's a pretty big, chewy word. It basically relates to something you didn't consciously perceive that somehow influenced your behavior. And we talked about it in the spatial neglect patient, right, who things that you don't perceive in the left field actually can alter your subsequent behavior. We had the house to flame example, and I'll show you that again. So here is a split brain patient. And by the way, these papers are great. And there's actually a couple books Gazette who wrote on this topic. They're really wonderful. So now the patient's looking here. They're fixating here. This is what the screen is going to show them, headstone, okay? And you say to the patient, because they're looking here, what do you see? And basically all the patient reports, of course, is stone, because head has gone into the right hemisphere and it's locked over there. So the patient doesn't see the word head. Now you just say, well, draw something. And what does the patient do? They actually draw a headstone with rest in peace on it. So this information, even though it didn't get to their conscious mind for them to be able to integrate it, the head part, somehow it was integrated. Somehow through some transfer, it must be, the callosum's gone. It has to be some other subcortical pathway is allowing the two hemispheres to integrate and preconsciously come up with the correct solution to headstone. And we talked about this before. Another example of this, a very, the classic example, which house would you like to live in? And the patients with hemispatial neglect. And the patient picks this one and they don't know why. And then you say, Ben, when you say which house, is dangerous, and they'll pick this one and they won't know why. Again, you're being influenced by things that did not make it to your, I don't want to say, conscious is not the right word, because your internal milieu is just as important as your interaction with the external world. But you're not, let's just say, in the mind's eye, it's not crisply there for you to see why your behavior is being influenced. Now, how it's being done, wow. These are huge, huge questions to figure out in terms of how we normally process information. And again, I think what you're seeing is the patients with neuropsychological symptoms provide a really interesting insight into what you're actually doing, at a rapidly integrating information at a subconscious to, in many cases, level. Okay, so let's talk about the classic neurological disconnection syndromes, not the surgical ones. These are the ones that I would see or I have seen as a neurologist. And there's three that I'm going to go over because they're really, really all interesting. In fact, the first paper I ever wrote a long time ago was on 3 patients with this particular syndrome. So there's idiomotor apraxia, which is essentially the same thing you saw in the split brain patient. The patient can do things normally with their hands. As soon as you say do something to verbal command with their left hand, they can't do it, right? They can't take the information from the left hemisphere, transfer it over to get motor control in the left hand. And then alexia without agraphia, which I'll talk to you about in a bit, and then alien hand syndrome, which we opened the course up with. If you remember, I think I showed you a picture, a movie of a lady with alien hand syndrome. So first, idiomotor apraxia. It's pretty simple. It really is a lesion in the anterior part of the corpus callosum. infarction, usually in the anterior cerebral artery, which does this distribution. The middle cerebral does this. Again, the posterior cerebral does this. So it'd be a small infarction, not very common, but if you have it, it's the commonest thing in the world. And when you get this selective lesion, the patient looks fine in many activities of daily and moving, etc. But if you specifically ask them to do something, to a verbal command, they can't do it with their left hemisphere. You see it you'll see it in patients with isolated lesions and even bigger lesions than this. But this is enough to do it. You've trapped, again, your left hemisphere is decoding. Please make the AOK sign with your left hand, and then normally your right hand would just do it. To get that information, that verbal command, and the motor sequencing, it has to come out of the left hemisphere, go through the anterior corpus callosum, and get to your motor structures here to make the AOK with the left hand, and you're disconnected. Same as the disconnection syndromes that the first patient movie I showed you. The next syndrome that is another posterior callosal injury syndrome. The idiomotor practice is the anterior callosum, disconnecting language and motor areas. Then there's a posterior syndrome, which gets the splenium, or the very back of the corpus callosum. And we know this. If I flash to you Boston, and you're fixating here, you'll just say effortlessly Boston. You don't know that your two hemispheres, how to move stuff around and put it back together, but you do it effortlessly. If you get a lesion, just like the lesion in the anterior callosum just gave you motor problems in the left hand, if you get a lesion in the splenium of the corpus callosum, and I present this to you, you look just like the patient with the surgical callosotomy, right? You basically say, I saw TON, because that came in to this left language hemisphere, and BOS went to the right hemisphere, and it was impeded from being transferred across the corpus callosum. And I want to reemphasize the speed of this activity. The time it takes to get a piece of information from your visual cortices in one hemisphere to the other cortices in the other side is 15 milliseconds. Bing. We're fast. Things are moving around in parallel at high speed. So the more the syndrome that we see not very commonly, but fairly commonly, is alexia without a graphia. Now, what is that syndrome? That's someone who has a lesion here in the splenium, so they can't get it across. And in addition, they have a lesion in the occipital cortex. This is commonly seen with a posterior cerebral artery infarct. A subset of these patients infarct the splenium in here. So if you're thinking, now this patient, I present Boston to them, and they got a big problem. They got a lesion in their left occipital cortex, so they have a right homonymous hemianopsia. They don't see TON. All that comes into their brain is BOS, which is going to this hemisphere, right? And it can't get knocked over. So this patient can't read at all. They're alexic, right? But because their left hemisphere structures are intact, they can still write. So they have alexia, can't read, without agraphia, because they still can write. It's a really fascinating syndrome. And you can actually see, you can get at how much can this hemisphere read? Well, you know what? Your right hemisphere can usually detect single letters. Right? It's not like it's completely absent any language capacity. So it's a very interesting, research model. These patients really produce some very interesting insights. So this is alexia without agraphia. You can't read at all. The patients can write. And what I do when I examine these patients in the clinic, I'll have them go up to the board, and I'll have them write a sentence out. Today is a sunny day in California. They write it right out. And then a couple minutes later, I said, go up to the board and, read it. And if I give them truth, they can't read it, right? They just can't read, but they can write. Alexia without agraphia. Very interesting syndrome. Again, a disconnection syndrome. So here it is in a little bit better detail. The lesions typically are lesions in the posterior cerebral artery. They actually pretty much all are. There's a few tumors that do it. Actually, I've seen one or two people who've had trauma who've traumatically torn their splenium, but they just have alexia in one field. They don't get an occipital infarction. So this is the classic lesion for alexia without agraphia. Your language areas are spared, so you still basically can write, and you can speak, and you can understand what people say to you. You just can't read. Okay, so the alien hand syndrome is another disconnection syndrome, which combines the ideomotor apraxia component with a lesion in the supplementary motor area, which is in the middle part of the frontal lobe, and it's in the distribution of the anterior cerebral artery. And what is the alien hand syndrome? We went over it a teeny bit in the beginning of class. The alien hand syndrome has the lesion that you would expect to produce ideomotor apraxia, so you don't have any verbal control of your left hand. Plus, you typically have lesions in your supplementary motor cortex, which produces a disinhibition of movement in your left side. Right? So your left side is kind of on free form, and because your language system can't get over here to say stop, your left hand starts doing spontaneous things. It just starts exploring the world without you wanting it to explore the world. So here would be it. The patient, if you volitionally, well, actually, I don't need to do this. This is already the apractic part. If I ask them to do a block, they're going to have a hard time doing it to verbal command. We don't need to discuss this. What I want to show you is a picture of the patient, of two movies of patients doing this.
BD is a 53-year-old woman who has suffered a stroke. As she sits talking with her doctor, her hands are at rest. Then, gradually, her left hand starts to move slowly along a strap on the wheelchair and then moves to her neck, where it begins to undo the buttons of her blouse.
All involuntary. This is the alien hand syndrome.
Are you telling the hand to do that now?
No, I'm not.
Do you feel like that's you doing that with your playing with your blouse?
No.
She can't stop it.
To me, it seems like everything on the left side wants to work by itself, for itself, and do what it wants to do.
Pretty good description of what's happening.
The right
to her
hand
hand.
doesn't do anything. We try to stop the left hand. The only way I can keep from not doing anything is to hold it.
That's it. Otherwise, it's
Compare
on its
this
own.
alien hand sign with the related symptom shown by a patient who suffers from unilateral neglect due to a right parietal lesion. BD does not deny that the left arm is hers, but she does think it is controlled by someone else.
Interesting. Can you imagine? And this is the young lady that we saw at the beginning of the class with the exact same phenomena. She had, now that we're farther into the class, you can see she has her right eye's droop. She actually has a third nerve palsy, and she ruptured an aneurysm. And this aneurysm produced spasm in a vessel, and basically the anterocerebral artery spasmed, and she had an infarction in her corpus callosum and her supplementary motor area. So let's take a peek. You're going to see the same phenomena.
All right. So can you tell me, ma'am, what's been going on with this left hand?
The past couple of days, my left hand has been doing involuntary movements that have been kind of surprising to the rest of my body.
And tell me, I see it's moving now. Are you making that happen, or is it doing it on its own?
It's doing it on its own.
Okay. And can you lift that arm in the air for me?
Yes, I can.
Give it a try. Good. Great. Put it back down. Now, tell me, the other day you told me that there was an interesting thing that happened with your hair. Tell me about that.
Yes, that was earlier today, actually. I was just laying in bed, and the nurses were coming around and asking how things were going. And things, I was saying, well, things are fine if I could just figure out who's pulling at my hair, because that hurts.
And who was pulling at your hair?
And they said, well, you need to let go of your hair So my left hand was apparently pulling at my own head.
And you didn't know
And
that?
I didn't know that. I didn't realize it until my hand kind of fell flat against my head and then draped itself down the front of my face.
Okay. And tell me, when you see this limb right here,
Yes.
do you recognize that as yours?
I do recognize it as mine.
And has that been the case the whole time, or has there been some times when that was not the case?
Usually the only time I don't recognize it as mine is when it's laying across my body and it's making some kind of random movement and I feel the movement. I think it's someone else making the movement.
You think it's not your limb, but it's someone else's that's draped across your body making the movement?
Yes, that's correct.
Okay.
Pretty amazing syndrome, giving you lots of insight into how you're actually organized. You can imagine how frustrating this is for the patients because you can't control your hand. Again, three really classic syndromes: idiomotor apraxia, and alexia without agraphia, and alien hand syndrome. These are like some of the core papers in behavioral neurology that really set the stage for understanding many, many future more sophisticated physiological studies on how your brain is organized. So just a couple other comments on the corpus callosum. There's a syndrome called agenesis of the corpus callosum. What does that mean? It means you never developed it. You never develop your corpus callosum. Oftentimes you don't know it's happened. You don't know you don't have a corpus callosum. Sometimes it's associated, if it presents and you know you have it, it means you probably have some other bad genetic midline abnormalities, right? Those present in kids often, or babies even. But in adults, you may have a selective deficit in development of your corpus callosum, agenesis of the corpus callosum. It's typically, but the incidence is about 1 in 10,000, but if you do enough MRI scans in your hospital for whatever, let's say you get an MRI scan because you've had a severe persistent headache, you may be picked up unexpectedly having an agenesis of the corpus callosum. So the question is, if you never developed a corpus callosum, how are your two hemispheres organized? So how do you think they are? Do you think they have lateralization or not? What would people guess if you've never developed a corpus callosum? They're not fused. You'll see they're just totally disconnected. But I'm talking about laterality. Do you think you develop language on the left? And there's some that say, why not? What? So how do you think the hemispheres are organized? Do you think each hemisphere can do everything? Yeah, you're right. That's exactly what you see. You don't get lateralization of function when you have agenesis of the corpus callosum. So here's your normal corpus callosum, and here's someone who has no corpus callosum. And interestingly, this is kind of a historical note that is irrelevant, but interesting. And this was an unexpected corpus callosum agenesis, by the way, who died of another cause, and this was found at autopsy. You see how the ventricles are shaped? What do they look like? What animal do they look like during Halloween? Pick an animal that's popular at Halloween. Bat. This is the classic bat winging of the ventricles that you can see on the MRI scan and you can see at postmortem. Just a little side note. Bat winging of the ventricles. So that's agenesis, and as was predicted. So here you can see normal corpus callosum. This person has about a 90% loss. There's a tad of anterior corpus callosum, and you'll see some people that are 90%, some people are 100, some people that are 70. This is about a 90. Your cingulate gyrus is not properly formed, but you can see that is not there. And in general, it's a midline deficit. It's probably something in the growth nectrin, or I don't want to get into the molecular biological aspects. If you know about it when you're young, then you got a problem. It will just be an ancillary finding to other even worse developmental abnormalities, malformed cerebellum, and so on. And as I mentioned, in adults, it's usually an unexpected finding on CT or MRI that has been obtained for a different reason. And in fact, for those of you interested in this, I know Rich Ivory's been studied. One of the faculty members has been studying these patients in some detail. I think he just had 7 or 8 of them out for a week for a whole series of motor control studies. And he's an expert in motor control. And as predicted and is true, the patients are less lateralized. They show language in both hemispheres. They can show spatial equivalence in both hemispheres, and so on. So with that, I'm going to stop, and I'm going to turn it over to Devin, who's a first year graduate. I'm going to. How do you do it?
No, I'm guessing it's this.
It's not.
Back and
it's
forth.
Yeah, back and forth, and then the bottom one's the pointer. That one.
This is next.
No, yeah, and that's that.
Cool.
Okay, so Devin is in a clinical psychology lab, but Sherry, right?
Yes.
Sherry Johnson, who's head of the clinical program, and she's interested in a lot of things. I don't think she's going to talk about her principal interest, which I was told is you're interested in factors leading to suicide in patients with major psychosis.
I'm just going to talk about mood disorders right now.
Okay, that's fine, but that's good. So here you go. You're all set.
How do I do this? All right. Can you hear me? Is that working? Cool. What do I just play with it? Okay. So last week, Manah gave us a great talk on some different aspects of the reward system. We also saw how researchers measure these different aspects of reward in various lab tests. And today I'm just going to talk about some individual differences in reward sensitivity. And I'm going to talk about it specifically in the context of mood disorders. So I have here just some of the symptoms of depression, and you might notice that many of these are tied to one's reward sensitivity. So anhedonia is a dampened response to reward salient stimuli. Many of these difficulties up here, like low motivation, low energy, they are deficits in processes needed to go after reward. So many researchers have considered to what extent are some depressive symptoms effects of an impaired reward system. So I'm going to present what we know about depression in terms of reward based on those 4 facets that Manah talked about last week. So first, wanting. So you guys will recall that wanting or anticipatory pleasure is the pleasure you get from just thinking about that delicious dessert you just ordered or the vacation you're going on maybe in 3 weeks. And not in 3 weeks, later than that. Hopefully someone here is. Somewhere in 3 weeks. And so she showed us that researchers can measure this sort of wanting aspect of reward with tasks such as the monitoring incentive delay task, or the mid task is the one up here. And the nucleus accumbens is active during reward anticipation before you receive a reward. So in a study by Brian Knudsen's team over at Stanford, they saw that compared to controls, people with depression are showing decreased activation of the nucleus accumbens during these types of tasks. So wanting is one set. Oh, that looks lame on your computer. Is one set. It's okay. It doesn't matter.
I think I got your original.
What do you mean?
Well,
No, it's fine. It's fine.
You sure?
Yeah,
It's on
yeah.
the desktop.
They can still read it. So wanting is one aspect of reward that seems to be impaired in depression. So what about learning? In reward learning tasks, some of which we went over last time, in the one that's presented here, rewards are administered trial by trial, but then there's also cues that are paired with rewards more often than others. So participants with depression were less likely in this experiment to integrate over time what cues are paired with reward and then respond more to those. So compared to controls, people with depression are less likely to modify their behavior based on prior reinforcement. Willingness to work. Experiments have shown that people with depression exert less effort for rewards. So, for example, in a task where the participant has an option to do an easy task for $1, let's say, and a hard task for more money, like $2, the depressed participants are more likely to choose the easy task. And then lastly, though, liking, or how much you actually experience pleasure from reward, is not impaired in depression. So interestingly, in these sort of sweet taste test tasks that we talked about, controls and participants with major depression are comparable. So this appears to still be intact. Okay. That one we're fine. So bipolar disorder, for those of you unfamiliar, is a mood disorder characterized by manic episodes in particular. So where people feel extremely happy or high, sometimes irritable. We see increased goal-directed behavior, so things like taking up a new hobby or starting a big project. Oftentimes getting into trouble by spending more money than they can, things like that. Mania is also characterized by confidence, optimism about the future, little regard to risk, and high energy and talkativeness. So similar to depression, there's some emerging evidence that's looking at whether there are reward processing abnormalities among people with bipolar disorder. But in this case, the construct of interest would be hypersensitivity to reward pursuit. So the evidence for reward deficits in bipolar disorder is definitely still developing, but I'll touch on a few highlights. So in a self-report measure of reward sensitivity, the BAS scale, or Behavioral Activation System questionnaire by Carver and White, some of the sample items are things like, when I get something I want, I feel excited and energized. I crave excitement and new sensations. Among adults with bipolar disorder, and even among students with mild subthreshold symptoms of mania, the BAS scores are significantly higher than for their counterpart controls. Certain neural responses to reward are consistently atypical in bipolar disorder as well. So during behavioral reward tasks in fMRI studies, we see elevated activity rates in the ventral striatum and the ventrolateral prefrontal cortex during the reward anticipation period of a task. So both areas involved in the dopaminergic pathways that we've discussed. And then lastly, there's some research that suggests bipolar participants are more willing to work for rewards. So in tasks where you need to press a button for a reward, the bipolar participants are pressing that button faster. In tasks that get increasingly difficult over time, participants are showing more task engagement. And then if we think about the fact that bipolar disorder, there tends to be this, potentially there's this heightened reward sensitivity. It might not come as a surprise that levels of ambition also tend to be elevated in bipolar disorder and people at risk for bipolar disorder. So this correlates with accomplishments in the creative domain. So you guys may have heard just amongst, I don't know, pop culture, that there are high rates of bipolar disorder amongst artists, authors, all sorts of creative endeavors. There are also high rates of bipolar disorder compared to other sort of jobs in entrepreneurship. So our lab has a study going on right now looking at entrepreneurs in the Bay Area with bipolar disorder. And so just to sum up, you guys can revisit this later, but depression, not all facets of reward are impaired. Bipolar disorder, there's some hints that the reward system may be elevated, but research is still forthcoming. I do want to make a quick plug that if you're interested in the reward system in psychopathology, so not just in mood disorders, but across psychopathology, our lab's doing a study that looks at reward sensitivity and also cognitive control across internalizing and externalizing disorders. So that is our lab's email address. Shoot us an email if you think you'd be an awesome RA for something like this. Yeah?
Is the elevated reward response in bipolar disorder only during the manic phase?
Great question. It is not. I would have to go double check, but one of the studies that I referenced on there was actually during the depressed phase of bipolar disorder. So in bipolar disorder, there's depressive episodes as well as manic episodes, and it seems to be elevated, at least in some of the research. They found it's elevated across. I don't want to take Nick's time, so come find me if you are interested in this.
So Nick's going to give his presentation. I want to finish these because the last lecture will only vet 30 minutes, 35 minutes of the main over what I think are some of the important highlights. So Nick's going to present now.
I got my thing. Hi, can you guys hear me? Yeah, great. I'm Nick. I am obviously one of the GSIs. Today I'm going to be talking about stress and motivation. So consider the lone endurance athlete. This athlete puts hours and hours of effort into an endeavor that may also come with quite a bit of stress and unknown rewards, just for a moment of what may or may not be rewarding. So this athlete is going to experience a lot of stress while they're trying to put this effort into this goal. So what exactly is stress? Now, when I talk about stress, I'm talking about the stress response, right? The stress response is a sort of set of particular physiological reactions and changes that result from real or imagined threats. Okay, and these threats can disrupt homeostasis and cognitive function more broadly. Now, as many of you may know, especially as you come into exam season, stress can be both adaptive and maladaptive. Okay, so too much stress leads to declines in performance, but just the right amount for certain people can lead to improved performance. So this depends on a number of factors like baseline neurohormonal factors and individual differences, right? So stress has quite a bit of clinical relevance. Okay, it's a core trigger for a number of psychiatric disorders, and it's crucial that individuals have functioning motivation in order to initiate actions that will lead to improved health outcomes. Okay, so what I'm interested in looking at is stress and motivated decision making. So how does stress specifically affect motivation? Okay, now we answer this question by looking at what we call effort-related decision-making. As Devin mentioned, we do a task where participants hold a hand device called a dynamometer. It's really similar to those little devices in like arcades that you squeeze and the little light goes up as hard as you squeeze. And it basically measures physical effort output. So we have participants squeeze this device in order to gain some sort of reward, and we vary how much they have to squeeze and how much reward they may or may not win using probabilistic outcomes. And we calibrate each subject's sort of maximal voluntary contraction, their maximal squeeze, so that we know that they're really working hard. Okay. So at the neural level, we know that these sort of cost-benefit decisions are encoded within the mesolimbic dopamine system. So nucleus accumbens and ventral striatum are super important for encoding expected rewards. And the subthalamic nucleus has been shown to be important for encoding the costs of effort. So under stress, the HPA axis, or the hypothalamic pituitary adrenal axis, is what sort of causes a lot of these sort of chain reaction events in your body. And these have been shown to disrupt the sort of baseline computations that encode subjective value. So the way that we look at this is we have people go into the scanner. We have them do this task where they're squeezing that device for rewards. And we use some discounting models from behavioral economics where after a little while, people are less willing to work hard for a reward that may not be worth that amount of effort. We then are going to integrate these neurohormonal measures such as baseline cortisol and other hormones like salivary alpha amylase that are shown to sort of track with the stress response. And we show after looking at enough of these sort of behaviors that people may be less willing or more willing to exert effort when they're experiencing stress. So that's what my PhD research is looking at. I haven't really started looking at the data yet, but I'm still collecting it, so that's where I'm at with what I do. So if you are interested in clinical cognitive neuroscience research. The same lab that Manon and Devin are in is currently hiring. We're looking for an undergraduate to learn how to operate an fMRI scanner. If you want to do this, you have to be here this summer. Please email me and let me know. This is really good for people who are pre-med and interested in any sort of medical field with the brain or future PhD hopefuls. Just email me and let me know. You have to have taken or will be taking in the fall intro physics and intro biology. Okay? So that's it for me. Thank you very much.
So Nick's in a neuroeconomics lab at Ming Shu in the economics department. You can see how brain science is affecting lots of fields across the campus. Okay, see you on Wednesday. But isn't that you feel guilty for doing wrong? No.
Shame is more like you think that you are like at your core not a good person, or you think that other people look down on you.
I see. So these are like the second order. Not low level. Embarrassment, shame, guilt. Yeah. Right? Level. Like stuff. I know a little bit about it because I'm working with Levinson. It's very interesting. So, yeah. Well, we got.
I thought wrapping something in with half of it already being presented would be easier.
No. I think it's perfect. I think it's perfect. Couldn't have been better.